Assalamu alaikum. Today our lecture about complication about stroke. Us, Dr. Ahmed Sibai, Assistant Professor of Neurology of the University. Dr. Ahmed, thank you so much for your time. Words cannot describe how grateful we are for your acceptance to speak and share your knowledge with us and help us to build the stroke unit in North Syria. Inshallah, Dr. Ahmed Sibai will explain the lecture in the English language, and the end I will speak in the Arabic, the conclusion about 10 minutes. And if anyone will ask, he can write in the chat, and the end we will ask the Dr. Ahmed Sibai. Dr. Ahmed, if you're ready, you can start.
أهلا دكتور، مرحبا بالشباب وشكرا على الفرصة إنه أعطيها الليكتشر. المحاضرة اليوم medical complications of stroke، الاختلاطات الطبية ما بعد الستروك. وبتعرفوا يعني ستروك هون عم نحكي عن الاسكيميك ستروك والهيموريجيك ستروك. فحتى ندخل بالموضوع، أول شيء حابب أقسم الاختلاطات type of complication into 4 subcategories. أول شيء complications related to pre-existing medical comorbidities, hypertension, diabetes, heart disease, etc. يعني المريض عنده ضغط، عنده سكري، عنده
Dr. Ahmed, you have a slide you are sharing? You have a slide you are sharing?
I do. Can you see it?
No one. Can you see? Can everyone see it?
No. We are see only your picture.
Yes. So,
طيب يلا لحظة شوي.
Yeah. Just sorry to interrupt you, but I thought that's.
معلش. وضحت هلا؟
Wonderful. But just if you don't mind, start the slide. Yeah, now it's all good.
Okay.
Dr. Ahmed, would you please to speak in English for our colleagues from Pakistan and Somalia?
Okay. So I'll try to keep everything in English then. You can see my picture and you can see the slides, correct?
Correct.
Now all good.
All right, so we'll first try to divide those complications into categories to try to understand them. So we have complications related to pre-existing medical comorbidities, hypertension, diabetes, heart disease, etc. So these would be the medical conditions a patient had before having a stroke. Complications as a direct consequence of brain injury itself. So these are complications related to something new happened after the brain injury. Number 3, complications which result from ensuing disabilities from resulting, sorry for the typo, disabilities or immobility. So patient being disabled or immobile for a long time due to the stroke can result in certain complications. So that would be the 3rd category. And the 4th and last category would be complications that result from stroke-related treatments. The treatment itself sometimes can cause complications. So keeping those in mind, we're going to start with the most common complications after stroke. Just give me 1 minute to readjust my screen here. So it's a bit, yeah. Give me 1 second here. Can you see all the slides clear?
Only the title of the slide.
Yeah.
Yes, now.
Now you can see everything. Okay. So why do we discuss those complications? Because they do have significant impact on patient. So medical complications of stroke have impact. So this is just, again, trying to remove anything that would interfere. Yeah, so the medical complications would have impact on the patient outcome. Obviously, it can also impede neurologic recovery, make it more difficult for the patient to recover. Cardiac complications, pneumonia, venous thromboembolism, fever, pain, dysphagia, incontinence, and depression are usually the most common complications after stroke and require specific interventions for prevention and treatment. So that's why those complications are pretty important to recognize and treat immediately, and that's why we're discussing them in this lecture. Let's start with the cardiac complications, which, as you would expect, are pretty common following a stroke. And that's, as you know, because a stroke and ischemic heart disease, they both share several risk factors. So underlying cardiac disease, such as AFib, valvular heart disease, or CHF, would increase risk of stroke and is common in stroke patients. On the other hand, stroke can provoke disturbances in autonomic control and predispose patients to cardiac complications. So what we're saying here is that the patient already have cardiac risk factors to start with, which put the patient at risk for stroke. And then after the stroke, those cardiac risk factors tend to play more role in complicating the patient medical condition. And on the other hand, the stroke itself can provoke further disturbances through the relationship with the autonomic nervous system and make those complications more likely to appear after a stroke. The occurrence of serious cardiac events in patients with stroke is actually high, and most serious complications occur early after stroke. So you will notice them relatively early in the first or second week after a stroke. Myocardial infarction is one of those potential cardiac implications. And here we should mention that cardiac enzymes in general usually elevates after stroke, but they are often minor. And that's usually below the cutoff for MI and possibly indicate a neurally induced myocardial damage or myositis. So I'm saying this because we don't want to jump into the diagnosis of myocardial infarction each time we have some elevation of cardiac enzymes. Cardiac enzymes could be minor and they don't meet the criteria for MI. Infarction of the right insular cortex, have been associated with such patterns of increased cardiac enzymes. However, and that's the main topic here, is that stroke induces autonomic dysregulation, and the physiological stress response due to stroke are factors that can contribute to increased incidence of myocardial infarction after stroke. So yeah, sometimes we have some minor enzyme elevation, but we can still have actual MI where the cardiac enzyme is above the cutoff, above the 0.8 cutoff of troponin elevation, where the patient actually have myocardial infarction. Patients with large vessel atherosclerosis and obviously large vessel strokes generally have a higher prevalence of coronary artery disease than those with small vessel disease. So that's something to keep in mind. So let's say someone who's coming with an acute MCA stroke, a large territory stroke, this patient would probably more likely to have cardiac complications compared to someone who is coming with a small lacunar tiny stroke in the basal ganglia. Patients should be screened to identify those with higher cardiac risk, and all stroke patients should be on a cardiac monitor. The use of modified cardiac stress test in high-risk patients might be safe for diagnosing coronary artery disease in post-stroke patients, because many of those patients can actually have silent coronary artery disease. And if the internist or cardiologist involved in this patient care suspect that CAD might be an underlying pathology and would like to jump early by making a diagnostic step, then a modified cardiac stress test would be safe after stroke. And when I say modified stress test, I'm not saying a stress test where the patient is walking on a treadmill, but more modified stress tests, such as using radionuclide testing, or dobutamine echo, etc. Cardiac arrhythmias is another potential medical complication after stroke. AFib, SVT, ventricular tachycardia, ventricular ectopy have been observed all after stroke. Abnormalities in EKG and cardiac arrhythmias might predate the stroke or rise as a complication. So it's interesting here that AFib itself can lead to stroke, but after the stroke itself, arrhythmias can also arise. AFib can become active again, or new arrhythmias can arise, such as SVT, ventricular tachycardia, etc. Prolongation of QTC in particular in patients with stroke is associated with increased risk of cardiac death. So that should be looked for, especially when the patient is on multiple medications to treat nausea, vomiting, metoclopramide, etc., medications for depression, etc. We have to watch for the QTC and should not allow the QTC to go above 500. And of course, watch magnesium, make sure magnesium is being replaced before the patient goes into a serious cardiac arrhythmia. Insular infarction, and we go back to this topic again, due to its association with autonomic control, are associated with abnormal cardiac repolarization and increased risk of vascular mortality. Right insular infarctions, increased risk of tachyarrhythmias. The exact mechanism is not very well understood, but we should always keep in mind when the right insula of the brain is damaged by stroke, there is always the potential for more autonomic dysfunction, autonomic instability, and therefore more cardiac complications are likely to happen in those patients. Congestive heart failure and cardiomyopathy. New onset MI, arrhythmia, acute hypertension, or iatrogenic complications like volume overload or change in medication might precipitate congestive heart failure in susceptible individuals. So maybe the patient is in the ICU and we're pouring IV fluids. That can cause congestive heart failure. The MI itself, or the myocardial infarction itself, can cause congestive heart failure, obviously, by decreasing the ejection fraction. Arrhythmias can also precipitate congestive heart failure exacerbation. Acute hypertension. I'm not sure if you are aware, but there's what's called the acute hypertensive response, where we see it when the patient comes in with an acute stroke. That can cause also flash pulmonary edema and throw the heart into temporary, sometimes heart failure. So all of these factors can cause the patient to go into congestive heart failure after stroke. A characteristic cardiomyopathy, stress cardiomyopathy, or Takotsubo syndrome with left ventricular apical ballooning, can occur as a complication of hemorrhagic or ischemic stroke. So this specific complication or characteristic cardiomyopathy is indicated by temporary ST elevation on V1 and V2 leads and the ECG, actually 1 to 2 leads on ECG, acutely followed by large negative T waves. And this is most frequent in V3 and V4. So just keep this in mind, because there is somehow increased incidence of Takotsubo syndrome after stroke. So BNP, or a brain natriuretic peptide, can be increased while ischemic cardiac markers are usually within normal range. And that's so important to understand here, is because we're not relying on the troponin elevation to diagnose this pathology. We have to be suspicious when the BNP is increased. We might not see a clear congestive heart failure picture, but then when we do the echo, we see this characteristic apical ballooning, which can occur as a complication of stroke. A hospital study that was done in Japan reported an incidence of about 1.2% within the first 2 weeks after ischemic stroke. A similar incidence was also reported in Mayo Clinic in patients with supraarachnoid hemorrhage, and that's why it's important to keep this potential complication in mind after patient comes in with an acute stroke. Particularly women with strokes involving the insular region or with extensive brainstem involvement seem to have a greater predisposition. And Takotsubo syndrome has been associated with sudden death, congestive heart failure, and recurrent thromboembolism. So this is a serious complication that the physician should be very vigilant about and consult cardiology immediately and start treatment. Prompt recognition of the syndrome could help avoid poor outcome, including congestive heart failure and recurrent thromboembolism and sudden death. So that was about the cardiac complications. You guys following me so far? I'm not hearing anyone. You guys following? Okay, I hope everyone is following. So I will continue with the pulmonary complications. So pulmonary complications, the most common and expected complication from the pulmonary system would be pneumonia. And pneumonia is one of the most frequent medical complications of stroke and the most common cause of fever within the first 48 hours after an acute stroke. When adjusting to other variables, pneumonia in stroke patients lead to threefold increased risk of death. And that's why it's so important to be vigilant about pneumonia and treat it. Most stroke-related pneumonias are believed to result from aspiration. Inhalation of colonized bacteria that seed pharyngeal material or that reside in the gingiva can lead to aspiration pneumonia, where aspiration of acidic gastric contents produce aspiration pneumonitis, sterile lung injury. So that's important for us to understand here where the pneumonia could be coming from, because that can affect treatment and management. So aspiration pneumonitis on one side is often self-limited and does not require antibiotics because it's a chemical irritation of the lung. It occasionally causes severe lung inflammation and acute respiratory distress. Whereas aspiration pneumonia, which is the bacterial infection, needs empiric antibiotic coverage for gram-negative bacilli and gram-positive cocci. So we should throw, vancomycin and zosyn, a broad-spectrum antibiotic coverage, and also we should cover anaerobic organism with clindamycin for aspiration pneumonia. So we should pursue a broad spectrum empiric antibiotic coverage because this is hospital acquired and multiple organisms are potential pathogenic causes for this pneumonia. Appearance of abnormalities on chest x-ray can be delayed, and I cannot stress the importance of this more. And the findings on chest x-ray can lag behind clinical symptoms and exam findings and typically show patchy areas of consolidation. So that's important because you might have this patient with a stroke that start having shortness of breath and fever, and then you check a chest x-ray and the chest x-ray is normal. That does not mean the patient do not have pneumonia. The pneumonia did not show yet on the chest x-ray because it can be delayed. So you should use your clinical suspicion, start treatment for pneumonia, and then repeat the chest x-ray the next day or the day after. And that's pretty important for us to keep in mind. In aspiration pneumonitis, which, as we said, is a chemical interaction, the chest x-ray findings might resolve rapidly if precipitating factors are controlled, while opacities associated with aspiration pneumonia can take weeks to resolve. So that's one way for us to find out how to differentiate between bacterial and chemical pneumonia versus pneumonitis is by knowing for how long the chest X-ray findings will last after treatment. Factors that increase risk for pneumonia are old age, more than 65 years old, speech impairment, severity of post-stroke disability, cognitive impairment, decreased level of consciousness, severe facial palsy, and brainstem strokes and dysphagia. So keep those factors in mind, especially dysphagia are important risk factors for aspiration pneumonia, as you would expect. Obviously, patients with cognitive impairment are more likely to aspirate, those with acute delirium, underlying dementia. And of course, the more severe the stroke is, the more likely the complications are. Swallow function evaluation, dietary modification in patients with dysphagia is obviously very important in those patients with stroke. And also studies show that even unilateral hemispheric strokes can lead to impaired cough and decreased expiratory muscle function. So it's not only the strokes that affect the brainstem, it's also the strokes that affect the cortex and cause hemiplegia that can also cause dysphagia and eventually aspiration. So those strokes tend to impair cough and decrease expiratory muscle function and put the patient at risk for aspiration pneumonia. Patients who are unable to handle their own secretions should be placed in a semi-upright position with frequent oral suctioning to decrease risk of aspiration. And in mechanically ventilated patient, and that's an important point, application of oral antiseptics plus frequent toothbrushing regimen lower the risk of ventilatory associated pneumonia. That's because, as you would expect, we are cleaning the source of bacterial infection that's coming from the gums by doing the oral antiseptics and the tooth brushing regime to lower the risk of having aspiration pneumonia from that bacteria that's staying in the gums. And then we have other pulmonary complications, oxygen desaturation and dyspnea we're going to talk about, and 20% of patients with stroke develop oxygen desaturation within the first few hours after stroke, and almost 2/3 are affected in the first 48 hours. This drop in oxygen saturation could obviously aggravate brain injury. The causes of this would be stroke can alter central regulation of aspiration, leading to sleep apnea or weakness of respiratory muscles. Another possible cause would be complications such as pneumonia, aspiration, atelectasis, and pulmonary emboli can impair lung exchange. Major hypoxemia most occurred in patients with pre-existing cardiopulmonary conditions. So patient already had, let's say, COPD or CHF, so that makes the patient more likely to experience oxygen desaturation and dyspnea after stroke. A small trial in acute ischemic stroke patients showed that high flow oxygen might be associated with transient improvement in neurological deficit. Though this study did not show that it has effect on the long-term disability or mortality, but it's worth noting that, putting high flow oxygen mask on a patient coming with acute stroke can provide benefit and improve and do some at least transient improvement in neurological deficit. Patients with acute stroke are recommended to be monitored with pulse oximetry, obviously, to maintain a target oxygen saturation level at or above 92%. Obstructive sleep apnea and central periodic breathing during sleep are commonly seen in patients with acute stroke as well. Sleep disoriented breathing is accompanied by episodes of hypoxemia, hypoxia, decreased cardiac output, and fluctuations in blood pressure that can exacerbate brain injury. So we should be aware of this potential serious complication of stroke. And advanced age, reduced left ventricular functions, and severe stroke are all important risk factors that put the patient at risk for such complication. Stroke severity and pharyngeal weakness don't correlate with the risk for obstructive sleep apnea. Most patients, so now we talked about periodic sleep dysfunction, but going back to obstructive sleep apnea, most patients with obstructive sleep apnea as a result of a stroke, as a complication of stroke, not the ones with pre-existing obstructive sleep apnea. Here we're saying that the stroke severity and pharyngeal weakness don't correlate with the risk of obstructive sleep apnea. So why do patients with a stroke then can have obstructive sleep apnea as a complication? Actually, most of those patients have typical risk factors such as high BMI and increased neck circumference just before the stroke. And it happened that the stroke makes it easier to go into obstructive sleep apnea. And most of those patients, sleep apnea improve with time. There's not enough evidence available regarding the use of treatment with continuous positive airway pressure. So if you apply CPAP on those patients who develop obstructive sleep apnea after stroke, there's not much of evidence that BiPAP will do much. Actually, most of those patients will improve with time. So we talked about the cardiac and pulmonary complications. We're going to move into the gastrointestinal complications. And obviously, one of the most common and serious complications in stroke is dysphagia. That's 37 to 78 patients with stroke. Like I said, not only brainstem stroke, but also cortical strokes, which can cause hemiparesis, can also cause dysphagia. So all the swallowing centers are located in the lower brainstem. Dysphagia occur frequently after a unilateral hemispheric stroke. In most patients, swallowing function improve spontaneously, and in some it becomes long-lasting. The meanwhile, should use swallowing therapy and dietary modification while the patient has speech difficulty, swallowing difficulty. Feeding can be achieved through NG tube, percutaneous endoscopic gastrostomy, or PEG tube is used in patients who cannot swallow after a few days. But you should always keep in mind that neither the NG tube or PEG tube can protect from aspiration. So yeah, it helps with feeding, but it does not prevent the patient of going through aspiration as a complication. And then GI bleed is another potential complication. And usually when we say GI bleed, we're referring to upper GI bleed. A hospital study, Davenport et al. Showed 3% frequency of GI bleed post-stroke. Risk factors would include stroke severity, history of peptic ulcer disease, cancer, sepsis, renal failure, abnormal liver function, and NG tube use. So all of these are factors that can put the patient at risk for upper GI bleed. Prophylactic use of H2 receptor antagonists, proton pump inhibitors, antacids, sacralfate are all effective in reducing risk of upper GI bleed. And here is an important point is about the use of H2 receptor antagonists. There is an associated increased risk of pneumonia, especially in patients with dysphagia. And PPI can also diminish antithrombotic effect of clopidogrel. So many patients with stroke are on Plavix or clopidogrel. And if you put them on a proton pump inhibitor like Protonix, it can diminish the antithrombotic effect of clopidogrel. Therefore, the use of these drugs should be reserved in patients with substantial risk of upper GI bleed and should be monitored for chest infections and drug interactions. And, you know, as a summary here, you can use those medications, but try to use them when you feel the risk is really high for peptic ulcer disease or upper GI bleed, because there's also the potential adverse effect of increasing risk of pneumonia with anti-H2 receptor antagonists and the risk of interaction with clopidogrel if the patient is on this medication. And then we have venous thromboembolism. And as you probably all aware, this is a very common complication after stroke. It includes both deep venous thrombosis and pulmonary embolism. DVT is a major concern post-stroke, particularly with limb paralysis. Studies showed 50% prevalence of DVT within the first 2 weeks after a hemispheric stroke when no DVT prophylaxis was used. So you have a 50-50 chance of going into a DVT if you don't use DVT prophylaxis. And pulmonary embolism can occur in 15% of patients with untreated DVT. PE is an important cause of for early death after stroke, most commonly between the 2nd and 4th week after a stroke. Prophylaxis with low-dose unfractionated heparin, the usual sub-Q heparin, or low molecular weighted heparin, like Lovenox, can prevent DVT and PE and lower risk of mortality. And obviously that's extremely important because if you don't, you see that the studies showed 50% chance of DVT in the first 2 weeks after a hemiparetic stroke when there is no DVT prophylaxis.
دكتور أحمد كأنه فصل النت عن دكتور أحمد السباعي.
الظاهر يمكن ها. Just wait a few minutes probably. I will text him.
So we're back into DVT and PE as potential complications of acute stroke. And like I said, PE is an important cause of early death after stroke, most commonly between the 2nd and 4th week after a stroke. Prophylaxis obviously is very important here with low-dose unfractionated heparin, usually 5,000 units Q8 or 3 times a day, or low molecular weighted heparin, like Lovenox, can prevent DVT and PE and lower risk of mortality. High-dose anticoagulation has been studied, but it increases risk of systemic bleeding or intracranial hemorrhage. Therefore, it's not recommended for prophylaxis. So the low dose of 5,000 unit Q8 of unfractionated heparin or 40 milligram of Lovenox once daily for patients with normal kidney failure is an accepted prophylactic dose. There is no need to go for the higher full dose of anticoagulation. And then recommendations is to continue with DVT prophylaxis as long as patient is immobile or have other risk factors. So, and that's because I'm here trying to answer the question for how long DVT prophylaxis should be continued. And the answer is there is no clear answer for how long. As long as the patient is immobile, have risk factors for DVT and PE, then DVT prophylaxis should be continued. In patients with intracranial hemorrhage, studies showed that starting heparin prophylaxis on the 2nd day was safe and more effective than being started on a later date, 4th or 5th day. So that's a common question that comes up. The patient has intracranial bleed. Should we do DVT prophylaxis or not? So the answer already been provided by the studies. studies also show that use of intermittent pneumatic compression, or what we call at the hospital SCDs, did not reduce risk of DVT or PE and was associated with a 4-fold increase in skin ulcers and necrosis and small increase in lower limb ischemia. So, applying SCDs does not prevent DVT prophylaxis, does not prevent DVT, and also actually can cause ulcers, can create problems in the skin. So there is no point of using SCDs in post-stroke patients. Coming almost to the end here, I would like to talk about depression. It's also an important complication post-stroke. The prevalence is about 33%, obviously increases post-stroke mortality. And the reason, because patients with depression, in addition to committing suicide, they're also less likely to participate in rehabilitative services, and they do have poor compliance with medications and worse overall recovery. But we also have to be cautioned, because there's been several studies that came up in this regard. Prescribing antidepressants after stroke was shown to improve mood, yes, but no effect on reducing disability or cognitive function. I do remember some studies that encouraged the use of SSRIs for every patient with a stroke, but a meta-analysis really found, after comparing multiple studies, about 13 studies, showed that using antidepressants, whether it's SSRIs or tricyclic antidepressants in general, did not improve disability or cognitive function after a stroke. Yes, it showed to improve mood, but we also have to be aware of the potential side effects that come with antidepressants, especially with the tricyclic antidepressants that can worsen delirium, such as amitriptyline and nortriptyline. Psychotherapy seems to be helpful in preventing depression after stroke, so there is potential benefit with that. Physicians should be vigilant about screening patients with stroke who have depression and treat when needed. So if the patient goes into a major depression or severe depressive symptoms, then treatment is justified. But generally speaking, prescribing SSRIs or other antidepressants to every stroke patient is not recommended. And lastly, here we're going to talk about fever. And one study showed that prevalence of fever was about 5% within a few hours after an acute ischemic stroke. In a different study, 60% of patients with ischemic stroke develop fever within the first 72 hours. So it's a very common complication after a stroke. Frequency of fever might be increased with intracranial hemorrhage, especially with the presence of intraventricular hemorrhage, and with increased severity of the stroke. So the more severe is, the more likely fever can occur, and with hemorrhagic versus ischemic, more likely to occur with hemorrhagic stroke. Fever can be secondary to fever. I'm sorry, I should have said infection, stress, or impaired central thermoregulation. And central hyperthermia, characterized by rapid onset of high fever, notable temperature fluctuation, and high mortality. So that's what's called central fever or central hyperthermia. It's reported in strokes affecting the brainstem, either directly or due to secondary compression. So when the stroke affects the brainstem, either directly or as a secondary compression, central fever would be expected then. Fever can exacerbate neuronal injury and lead to worse outcome, particularly in patients who have early rise in temperature after stroke. And that's why fever should be addressed immediately. The cause should be sought and antibiotics should be started. Fever should be promptly treated and cause of fever should be sought. And lastly, we're going to talk about the acute ulcers, and poor mobility and incontinence increase the risk of skin breaks. The sacrum, buttocks, and heels are usual sites for decube ulcers. Early mobilization, turning patient every 2 hours, and the use of padded heel boots and specific air mattresses can prevent their development. Other complications, which I'm not going through in detail, but just to mention them in addition to the complication that we have went through, are fecal incontinence, urinary incontinence, urinary tract infections, hip fractures, pain, and fatigue. So this would complete the list of medical complications. And as you see, there's plenty of complication that can happen after stroke that we should be aware of and vigilant about early diagnosis and treatment. That completes my lecture.
الله يعطيك العافية دكتور أحمد ويبارك فيك.
الله يعافيك.
نحن خلال يعني إن شاء الله مو أكثر من 10 دقائق رح نحكي مختصر اللي حكاه الدكتور أحمد. صوتي مسموع واضح إن شاء الله دكتور أحمد؟
إيه سمعنا. أوكي.
هلا الاختلاطات ممكن تنقسم إلى اختلاطات قبل الستروك مثل الأمراض المزمنة الضغط والسكر والأمراض القلبية. ممكن الاختلاطات تكون مرتبطة بالأزيد الدماغي أثناء الستروك أو النزف. وممكن الاختلاطات كمان القسم الثالث إنه بعد الستروك ممكن يكون المريض يقعد ويكون في عنده اختلاطات، وبكون أحيانا اختلاطات مرتبطة بالعلاج. هلا تأثير الاختلاطات نحن بندبره مشان يكون نتيجة العلاج تكون جيدة. ومن التأثيرات كمان التأثيرات القلبية، ذات الرئة، الDVT، الحرارة، الألم والسلس البولي والاكتئاب. بلش الدكتور أحمد بالاختلاطات القلبية مثل الرجفان الأذيني وآفات الصمامي وقصور القلب الاحتقاني. غالبا بيكونوا مترافقات مع الستروك لأنه نفس عوامل الخطورة بتكون. أغلب الاختلاطات القلبية بتكون بالأسبوع الأول أو الثاني بعد الستروك. بلشنا بالاحتشاء القلبي. الاحتشاء القلبي ممكن الأنزيمات القلبية ترتفع بالاحتشاء القلبي بعد الاحتشاء الدماغي، ولكن ما بتوصل لدرجة أو نفس المستوى بالاحتشاء القلبي. ممكن اضطراب الشدي يكون عامل بعد الستروك يؤدي للاحتشاء القلبي. غالبا التصلب العصيدي بالدماغ تترافق مع التصلب العصيدي بالشرايين الإكليلية، لذلك ممكن المريض بعد الستروك يصيبه احتشاء قلبي. يفضل بعد الاحتشاء الدماغي مسح الشرايين الإكليلية أو إيكو قلب لنفي الأمراض الصمامية والإكليلية. الاختلاطات القلبية الثانية هي اضطرابات النظم، منها الرجفان الأذيني، التسرع فوق البطيني والرجفان البطيني. تطاول QT ممكن يكون مع مريض الستروك وبيؤدي لارتفاع الوفاة. ممكن احتشاء الرايت انسولار يؤدي إلى تسرع القلب. الاختلاط القلبي الآخر هو قصور القلب الاحتقاني واعتلال العضلة القلبي. ممكن يكون سببه الاحتشاء القلبي الحاد أو ارتفاع الضغط الحاد أو اضطرابات النظم أو فرط الحمل. الاختلاطات الصدرية أشع شيء هي ذات الرئة، وغالبا بتكون هي سبب الحرارة بعد الستروك. وأشيع سبب لذات الرئة بعد الستروك هو الاستنشاق. طبعا التغطية بتكون إيجابية سلبية جرام. عوامل الخطورة اللي بتسبب هي ذات الرئة الاستنشاقي، ممكن العمر أكثر من 65 سنة، اضطراب الكلام، اضطراب الوعي، واضطراب البلع. في نقص التشبع وضيق النفس كمان من الاضطرابات الصدرية اللي هي 20% ممكن نلاقيها بعد مرضى الاحتشاء. ممكن تكون بسبب مركزي احتشاءات أو جزع الدماغ، أو ممكن بتكون من الأسباب الثانية اللي هي ذات الرئة الاستنشاقي والتوسع القصبي. مريض الستروك لازم تكون أكسجته فوق 92. بعدها في الاختلاطات الهضمية. الاختلاطات الهضمية عسرة البلع نلاقيها عند 37 ل 78% من مرضى الستروك، وإصابات جزع الدماغ غالبا بتكون موجودة. منشان ننقل المريض من الاستنشاق ممكن يجي تيوب، ممكن تثمين من المعدة، ولكن ما بتوقي 100% من الاستنشاق، يعني بتساعد ولكن لا توقي 100%. هلا النظف الهضمي ممكن 3% نشوفه عند مرضى الستروك. عوامل خطورة ممكن سيفير ستروك، وممكن سبب قرحة، السرطانات، القصور الكلوي، الاضطرابات وظائف الكبد، ممكن يكون الانجي تيوب نفسه يعمل نزف. هلا الدي في تي والصمم الرئوي، الدي في تي 50% بتكون اول 50% من الدي في تي بتكون اول اسبوعين بعد الستروك. 15% بتصير صمم رئوي، بتصير صمم رئوي عند 15% عند المرضى الغير معالجين من الدي في تي. الصمم الرئوي هي سبب مهم للوفاة بعد الستروك. الجرعة الوقائية من الهيبارين يمكن أن تقلل السبب من الإصابة. مريض الستروك لا يعطى جرعة كبيرة من مضادات التخثر الوقائي خوفا من النزيف الجهازي والدماغي. مريض النزف الدماغي، هاي الدكتور تامر سأل عنها. مريض النزف الدماغي ممكن أن نعطيه جرعة هيبارين وقائي في اليوم الثاني، والأفضل باليوم الرابع أو الخامس.
لا معلش، هون تصحيح. الدراسة يعني أظهرت أنه باليوم الثاني الأفضل من اليوم الرابع أو الخامس.
تمام. الاكتئاب، الاختلاط، الاكتئاب 33% ممكن نشوفهم عند المرضى. هي غالبا بتكون انه المريض يعني كان ما في شيء، فجأة صار في عنده يعني مقعد، بنلاقي الاكتئاب. ممكن علاجه مضادات الاكتئاب والدعم النفسي. الحرارة 5% ممكن تكون بعد 5% بعد ساعات من الستروك، و60% أول 3 أيام. طبعا الحرارة ممكن تكون ارتكاسي، ممكن تكون أولي. ارتكاسي ممكن تكون نزف الدماغ ضمن البطينات، أو اضطراب مراكز تنظيم الحرارة بالدماغ، وممكن تكون بسبب ذات الرئة. قرحات الأضجاع
أو أي سبب للإنتان، يعني ذات الرئة
أو أي سبب إنتاني. تمام. قرحات الاضطجاع هي اللي نشوفها عند المرضى الستروك بسبب قلة الحركية، غالبا هي بتكون أسفل الظهر والأقدام. طبعا تقليب المريض كل ساعتين، والفرشاة الهوائية. في اختلاطات أخرى، السلاسل البرازي والسلاسل البولي وإنتان جهاز البولي، وكسور الفخذ وعنق كسور الحوض وعنق الفخذ، والألم والتعب.
دكتور أحمد ما شاء الله، الله يجزيك الخير، رائع.
الله يسلمك دكتور ماهر.
الله يسلمك. مين معي؟ دكتور ماهر.
دكتور ماهر.
يا جزاك الله خير دكتور أحمد سباعي. بالمناسبة دكتور أحمد سباعي هو حيشاركنا إن شاء الله بتغطية حيكون له دور إن شاء الله بتغطية وحدة الجلطة الدماغية والستروك بروجرامز إن شاء الله. اوفر فيو رائع ما شاء الله.
شكرا لك
دكتور أحمد. أنت خذ الكويشنز بعدين، أنا هاف كويشنز، بس خذ الكويشنز الموجودة.
دكتور ماهر، دكتور تامر هو مقيم عصر المشفى، سأل عن التمييع.
I think دكتور أحمد already
من
answer ما؟
الدي تمييع الوقائي من
ايوه. بدك بالعربي ولا انجليزي رد؟
لا
انجلش لانه في طيب
ليش؟
بس لانه في اتندنس، في انجلش اتندنس لانه من الصومال.
طيب DVT prophylaxis was already mentioned in the slides. يعني it's important to do DVT prophylaxis on all stroke patients, and if the patient has a bleed, intracranial bleed, then it's safe to start a low dose heparin on the second day. No need to wait for the 4th or 5th day. That's what the study has compared about potential complications and so forth. So at least on the second day of the stroke, DVT prophylaxis should be started even if the patient has intracerebral hemorrhage. If we don't, there's 50% of chance of DVT in those patients without DVT prophylaxis. So that's for prophylaxis, but for full dose anticoagulation, this is different story. I don't know if his question was about that, but there is no need to use full dose anticoagulation for prophylaxis purposes only. But if you have another reason such as AFib, DVT, PE, and you want to start anticoagulation with someone with a stroke, that's actually a different topic, different discussion. There are several factors that would affect this. The size of the stroke, the location of the stroke, supratentorial versus infratentorial. Generally speaking, if you have medium to large size stroke, it's preferable to wait for 3 to 7 days on full dose anticoagulation. Now on DVT prophylaxis, on full dose anticoagulation before committing the patient to such, heavy anticoagulation to avoid risk of hemorrhagic conversion. Any other question?
Another question, Dr. To right insular can elevate the myocardial enzyme?
Yeah, so the exact mechanism of how this happens is not really understood. Speaking in general, all strokes can cause a tiny increase in troponin. We call it troponin leakage. It's below 0.6. So 0.1, 0.2, 0.3. In particular, in right insular cortex strokes, this increase in troponin can be further. But this doesn't mean that every troponin elevation is an MI.
I have a question, Dr. Ahmed. How, this is always, I find it confusing about the diagnosis and management of chemical pneumonitis versus aspiration pneumonia.
Mm-hmm.
Yeah.
Well, it's sometimes difficult just to tell from the appearance on the chest X-ray. Generally speaking, you have to treat with empiric antibiotics regardless for both. And retrospectively, by looking back at the chest X-ray, you can tell that this was probably a pneumonitis because it took just a few days for the chest X-ray findings to resolve versus it stayed for a few weeks. Then you knew that you were treating with a pneumonia then.
But from symptoms perspective, can you patients' initial symptoms to distinguish between or not really?
So the symptoms are very similar. Obviously, the fever would be more prominent in bacterial pneumonia, but the pictures are pretty similar and easy to confuse. Yeah, in post-stroke. So,
another question is do you consider in ischemic stroke is DVT preventions very good, except if you go for thrombolysis, then you hold it for 24 hours, then you put the patients on DVT preventions. Once there is, you repeat the CT 24 hours per protocol. But the ICH, do you usually repeat the CT in 24, 48 hours to be sure there's no hematoma expansions before you subject them for prophylactic Glixan or lomotriptan?
I mean, obviously, patients with ICH are going to go into repeat CT head on a daily basis regardless. But this study showed that even if you have intracranial hemorrhage, regardless, a small dose of DVT prophylaxis was actually okay to be used. And that can be a little bit counterintuitive and raises anxiety for clinicians. But the study was pretty specific at answering that question compared to the 4th or 5th day, of starting a small dose. Because it's a tiny dose, it doesn't really contribute much. I see that neurosurgeons usually have, a little bit more, are more likely to use DVT prophylaxis than neurologists, because they see a lot of those bleeds and they see that, a small dose of DVT prophylaxis is probably not going to cause a disaster with the ICH.
And the the presence of DVT in the presence of ICH is a disaster.
The presence of DVT is a disaster because then you will need a full dose of anticoagulation. And in those patients, you can consider IVC filter, obviously, as one solution. Or, the patient is actually stuck between, between the DVT and the risk of anticoagulation. And that's why using the prophylaxis would prevent going into that disaster.
Dr. Ahmed, Dr. Muaz Rajab asked the dose of low molecular heparin for prevent DVT.
Low molecular weighted heparin is actually more effective, slightly more effective than unfractionated heparin, the sub-Q heparin. But pretty much both are similar efficacy, generally speaking, Lovenox or heparin.
Thank you, Dr. Ahmed. Can I ask you, when we treatment depression after stroke, tricyclic, the bitter or the SSRIs? What is the drug of choice of depression?
So if you have to choose an antidepressant, then please choose SSRI and not tricyclic. But what I try to focus here on this study, that we used to put everyone on SSRI after stroke, because there's some studies that came up which said, well, they improve disability, recovery, and so forth. So that's not true. So you only treat with an antidepressant if the patient have severe symptoms.
Yes.
And if you have to treat, then start with SSRI, because it has a lower anticholinergic profile. So the preferred agents would be Zoloft and Celexa or citalopram. Those medications have lower anticholinergic profile compared to amitriptyline or nortriptyline, for example.
Yes.
Yeah.
Yes, thank you.
Yeah. Any other questions?
Dr. Tamir asked another question. If we have ischemic stroke and convert to bleeding stroke, we must stop the aspirin or Plavix.
So, yeah. Well, that's also another big discussion, and you need to find out if the patient has drug-eluting stent versus bare metal stent. So the hemorrhagic conversion, it depends how big is the hemorrhagic conversion. Sometimes you see mild petechial hemorrhages in the area of the stroke. Probably aspirin is fine, but Plavix is probably the most troublesome here. I probably would stop Plavix, but I would consult with a cardiologist first to make sure Plavix, stopping Plavix here is not going to create stent rethrombosis. So these are case-by-case basis. There is no universal rule. It depends on the size of the bleed, of the hemorrhagic conversion. It depends on the indication, why Plavix was started at the first place. And we have to get a cardiologist involved in those cases.
And that's all the question, Dr. Ahmed. Thank you very much for the lecture.
Thank you, guys, and feel free to reach out to me if you have any questions in the future.
And so,
Thank you very much, Dr. Ahmed. It was wonderful. And I think the lecture will be broadcasted on the website.
On the website, yeah. So I put the reference at the end of my lecture.
Wonderful.
This is mainly taken from a Lancet journal with the name Medical Complications After Stroke. So for the fellows, if they want to go over more details, they can go over this reference and download the article. The article, unfortunately, has to be paid for to download, but it's actually worth it. And it's probably one of the best articles I have read in this subject.
Wonderful. Good. Excellent.
Sounds good.
Excellent. Excellent.
Yeah.